Uh, and then I lost my little welcome script here. Just a second. All right. Hello, everybody. My name is Corey Luebbering, and I am the PBR and coordinator at DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let us take a moment for the housekeeping rules of the webinar. First of all, please feel free to introduce yourself in the chat and tell us where you are from. We also invite everyone to turn on their cameras if they so wish, so we can be united as an OMM research community. Second, if you're having technical issues during the webinar, please put a message in the chat. We'll try to help out best that we can. Third, if you have questions or comments during the presentation, please feel free to type them into the chat and we can address each other's questions or comments there. Also, we will have time for discussion and questions at the end of the presentation. And lastly, please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. And today is our Let's Talk About OMM Research Journal Club entitled, Does Adding OMT to Standard of Care Help in Managing Anxiety with Dr. Arlene Dijamco? So Dr. Arlene is a graduate of Harvard College and Emory University School of Medicine, where she completed her pediatric residency at Albert Einstein. After finishing her residency, she began a 2-year integrative medicine fellowship through Dr. Andrew Weil's program at the University of Arizona. Here she explored a vast array of powerful modalities beyond conventional Western medicine, and the one that impacted her future the most was cranial osteopathy. And with a holistic approach to health and emphasis on the soul's journey, Dr. Dijamco serves on the board of Dr. Gladys McGarry's Foundation for Living Medicine and currently has her own practice in Roswell, New Mexico. And so with that, help us welcome Dr. Dijamco.
Thank you. Thank you, Corey, for that introduction. And just to clarify, I'm in Roswell, Georgia.
Oh, Georgia. Sorry, my apologies. I apologize.
And this topic is really near and dear to my heart and my practice and the Degenhardt series and a lot of my life's work. And my undergraduate was in psychology. So I feel like I'm also circling back around to be talking about these things in an academic way. And it's really an honor to be here and to be able to present for DO-Touch because I've also learned so much in the process of preparing for this presentation. I picked this study. This was an article on does adding OMT to standard of care help in managing anxiety? And I picked this study because there were prospective studies measuring changes in anxiety symptoms with the addition of OMT to standard of care treatment. And it's this working in collaboration that we can integrate this into regular medicine, into care, and it's not necessarily have to be in place of. So to take a more collaborative approach. There's some updated statistics on anxiety. This is from a 2022 CDC report. So about 1 in 5 people are experiencing some symptoms of anxiety, almost 20%. So this is up from 2019. And of course, we know that the pandemic had a lot to do with that, as many other things have been going on in the last years. Anxiety is more common in young adults, 18 to 29, women, adults with less than high school education, and those that are below the federal poverty line. There is a long history of using OMT to treat mental illness. This is a picture of the Still Hildreth Sanatorium, which is located in Macon, Missouri, opened from 1914 to 1968. And it was founded by Arthur Hildreth as president and superintendent, along with A.T. Still's sons, Charles E. Still as vice president and Harry M. Still, DO, as secretary treasurer. The mission of the Still Hildreth Sanatorium was to provide osteopathic treatment for mental and nervous diseases. So by the end of the first year, the hospital had 70 patients. A new railroad was built to accommodate the new activity in Macon, Missouri, because of their work. It's beautiful. This was the last letter from Dr. Still in 1917. It was written meant to be intended to send out for a holiday note. And he talks about the Still Hildreth Sanitarium. He says, "Dear boys and girls, I know you are keeping your eyes on the progress that is being made at Macon, Missouri in the treatment of mental and nervous diseases. We have a great deal of experience. My personal experience covers a period of something over 50 years in the treatment of mental cases. But until Arthur Hildreth and the boys, Charlie and Harry Still, became interested in the Macon Sanatorium, we never had a place where we had a chance to look after this class of patients. I've always contended that a majority of the insane patients could be treated successfully by osteopathy, and the success that the boys have been having in the last 3.5 years bears out my faith, and I'm very anxious for the entire profession to know of the work that is being done." So there's a long history of OMT being helpful for a mental illness. And Leslie Ching, DO, did a nice review of the history and chart review of the Still Hildreth Sanatorium. And on the right side, you can see all of these various admission diagnoses, including anxiety. That was the third most common thing. And then on the left side, there's a table showing the percentage of total recovery of people with schizophrenia was about a third, 35%, compared to another psychopathic hospital, 3%. So we have a foundation here, and we just need to continue to expand on it and keep this dialogue going, so that it's not only not lost, but that we can expand on it and integrate it into regular practice. So how could OMT potentially help with anxiety? We know this anecdotally in so many ways, and there are some studies around. I won't go through every single detail here, but we're going to focus on the studies that we have on hand. But how could it potentially help? Through musculoskeletal system, by reducing tension in the body, addressing the autonomics, including the HV axis function, making sure the vagus and sympathetic chain pathways are unrestricted, through circulation and visceral organ function, improving the circulation to all visceral organs like the adrenals, the gut, including arterial flow, venous drainage, lymphatic circulation. The cranium and the CNS, improving flow to and from the cranium, including emotional processing centers, the limbic system. And of course, improving the breathing, respiration, freeing the diaphragm and sacrum. And we have that gut-brain connection. So improving digestion, about 95% of serotonin is produced in the gut. So there is a lot of potential here. And OMT is much more than touch therapy. And there's some other articles here talking about it. The purpose of this review article is to give an evidence-based question, an evidence-based answer to the question, does adding OMT to standard of care help in managing anxiety? And this was written in this journal, Evidence-Based Practice. And the type of article this is called a help desk answer. So HDAs are tightly written research articles. They're very short. It's a synopsis of the literature that's on hand. And they provide some sort of evidence-based answer. So when I first looked at this article, it was very short, had all these numbers on it. And I was wondering if we would have enough to talk about. We have more than enough to talk about. And I also dug into the original articles that this review article is based on, this HDA article is based on. So the HDA article is a synopsis of two small studies. It compared, it took this summary of each of these studies and their results and how they were set up, and came up with an answer. So the two studies that were looked at were this one from the Journal of American Osteopathic Association, that's on the left, the effect of osteopathic manipulative therapy on generalized anxiety disorder. So that was a 2020 study. And then we have this study on the right, osteopathic manipulative treatment in patients with anxiety and depression. This was a pilot study. This was in the AAO journal, and this was published in 2021. And those dates will be important too as we go on. So to cut to the bottom line of what this article said, it was written at the top, and this was their synopsis. Maybe adding OMT to standard of care potentially may decrease anxiety symptoms by up to 50% after 10 weeks. So now let's go look at the details of how they came up with that. So first, we'll just take a look at the definition of generalized anxiety disorder, because both of these studies were looking at that. These were patients being treated for anxiety. So they have a diagnosis of not just mild anxiety, but warrants treatment. It's excessive anxiety and worry for at least 6 months, difficulty controlling the worry, and you have 3 or more of the following features in the last 6 months: restlessness, fatigue, difficulty concentrating, tension, insomnia, irritability, and it impairs their social and occupational areas. And this anxiety is not attributable to any physical cause. So I'm just going to do like a side by side to be able to go through the information more quickly. And in doing this, it actually is great because it gives us some ideas too of where where the strengths of the studies, where we could improve on. And so the first study, on the left side at least, this was an open label, non-blinded prospective study with no control group with an N of 26. And then the study on the right that we're reviewing is OMT in patients with anxiety and depression, a pilot study. This was an open label, non-blinded prospective controlled study. So they had a control group to compare it to. So that had an N of 20. And this was comparing a touch versus no touch group. There was no sham group. So for the inclusion criteria, this study on the left, it looked at adults with a diagnosis of generalized anxiety disorder, and they had a Hamilton Anxiety Rating Score of over 20, who did not achieve remission after 8 weeks of standard treatment, and that was undefined. You know, what's interesting to note for that, in the review article, in the HDA article, they actually made an error, and they said it was mild to moderate, that this study was looking at mild to moderate anxiety, and it's not true, because the Hamilton score of greater than 20, and within the study, they said they're looking at moderate to severe. So this is where, looking at the details of the study is actually really important. I was surprised to pick up on this error because it was such a short article that every word mattered. And to have that kind of error makes a difference on how you're thinking about the results. And then the study on this second study here, the OMT in patients with anxiety and depression, this was also looking at adults over 21 years of age actively being treated with psychotropic medication for anxiety and or depression by either their primary care physician or psychiatrist. Now, in both these studies, they don't say how they are being treated, like what was the standard of care. So that was just left up as, okay, they're being treated somehow, and we don't have any data on that. For the exclusion criteria, I've highlighted just some differences in both of these studies so we can see how they arrived at their results. The first study, you could not have any other Axis 1 psychiatric diagnoses. They left out severe depression, and they used this Hamilton depression score of greater than 15. 17 to 23 is moderate depression, so it's kind of right in the middle of moderate and then above to severe depression. No other mania or bipolar, receiving other forms of manual therapy, any alcohol or drug use, significant risk of suicide, any cognitive disorder or dementia, pregnancy or lactating, changes in medication during the study period, and any other serious illness, organic disease or serious illness. And then on this second study, they were actually looking at both depressed and or anxious patients. And so they had actually 2 subgroups, depressed patients and anxious patients. But if they had any other Axis 1 psychiatric diagnoses, they also left that out. It's interesting that they included this history of trauma and abuse, because we know that so many people have some kind of history of trauma or abuse, and that does contribute to anxiety and depression. And there is a chance that some of this history is not even known. So I'm curious as to a little bit more detail about that because everyone has had some sort of trauma, and so I'd like to know what was defined as trauma in this. Also, cognitive issues such as mental retardation, Down syndrome, traumatic injury to the cervical, thoracic, or lumbar spine, or herniated disc, any other serious illnesses, pregnancy, seizures, and of course, kids were out of the study. The OMT intervention, so this was interesting because they were slightly different in the two studies. In this one on the left, it was a full hour for the first session, and then about weekly over 5 sessions over 8 to 9 weeks. And this was considered a black box study design, which is very interesting. This requires an individualized approach to OMT for each participant. And in this, you get to leave it up to the osteopath as to what this person needs, and then how they treat them is completely up to the practitioner. Now, the other study, this one on the right, they had 60-minute session, and they had weekly follow-up sessions for 8 weeks, so there were 8 visits total. And they had an OMT assessment and treatment. This one was done with some kind of a protocol, and so we'll look at that in just a little bit. But it's a little bit, it's different than having a black box study design, and just want to keep that in mind in terms of like what we're seeing in the results. So OMT intervention setting, this is also curious. Now, this kind of level of detail was not in the review article, the HDA synopsis article. I had to dig into the individual articles to get all of this information, but I feel that it lends to the understanding of these studies and gives you more information of how to look at them. So this first one, it was at this anxiety and mood disorder private practice that also offered some holistic services, including naturopathic and other services. The OMT treatment was also provided by a foreign-trained osteopath, and she was the primary investigator. And the other investigators did the screening and psychiatric assessments. The study on the right was done in a psychiatric residency program in a hospital in Queens, New York. And so it was the residents that were treating under the guidance of their attending physician. And the participants completed the questionnaires in the same room as the OMT with the patient in the seated position, but it didn't have more information about how the questionnaires were given, who was collecting the data. I'd like to assume that it was a different person and not the practitioner, the osteopath, the resident that was treating them, that was also giving them the questionnaire. But since they didn't specify that, it's not clear. Then we look at the measures examined. So this study on the left, their primary efficacy endpoint was using the Hamilton Anxiety Rating Scale, HAM-A, which is a clinician-administered scale. They also had some secondary measurements using the Beck Anxiety Inventory and the Intolerance of Uncertainty Scale. And again, the initial screening was done by a psychiatrist using the MINI International Neuropsychiatric Interview, as well as the HAM-A and HAM-D. So HAM-D looks at depression. So over a certain value, they were excluding that group if it was over HAM-D over 15. Now, the scales that were used on this other study on the right was the GAD-7, Generalized Anxiety Disorder 7, and the modified Harvard National Depression Day Screen. That one was for looking at depression, to have 2 groups, anxiety and depression. These could overlap. But for the purposes of this discussion, we're just looking at the anxiety subgroup. There was a part 2 to the study. They also gathered information on this musculoskeletal screening numeric rating scale, NRS 11, but that is not our focus for today. So to understand the measurements, I thought I would just talk very briefly about each of these tools because it makes a difference in terms of your tool of measurement makes a difference in your results. And understanding your tools will help you understand if you are measuring things, that would give you the results you're looking for. So the response to the HAM-A scale was considered to be a reduction of 50% of symptoms, and remission was defined as a score of less than or equal to 7. So you can see here, less than 7 is no or minimal anxiety. Mild anxiety is 8 to 14, moderate 15 to 23, severe anxiety is greater than 24. This is updated scoring of the HAM-A, just to keep in mind, because there's other kinds of scoring. And so you do have to know like what the researchers are using for their scoring system. The Beck Anxiety Inventory is a self-report scale versus the HAM-A is clinician done. The clinician is asking the questions. So there's a bit more back and forth. This is a self-report 21-item scale, 0, 1, 2, 3. Is scored, and you can get a score range from 0 to 63. So under 7 is minimal, 8 to 15 mild, 16 to 25 moderate, 26 to 63 is severe. And in some of the studies on the Beck, the scores are tend to be higher for panic, and we'll look at this a little bit more in the discussion. Intolerance of uncertainty scale. This is an interesting one because intolerance to uncertainty is a predominant characteristic of general anxiety disorder and likely shared with other emotional disorders as well. This is a self-report scale, just like the Beck. It's a 27-item scale using 1 to 5. The score can range from 27 to 135, and there isn't a really defined scoring system. So there's no defined range for severe. This is the measurement used in the second study. So this is the GAD-7, and this is the scoring system on the right is 0 to 4 minimal, 5 to 9 minimal, mild, 10 to 14 moderate, 15 to 21 severe. And many of these are free to use. The Hamilton is public domain. The Beck is by purchase. Intolerance of uncertainty is also public domain. The GAD-7 is also public domain. This was the hand screening that they used that was for depression. The statistical analyses that were used for the study on the left was SPSS statistic version 24, Shapiro-Wilk test for normality, and then they used paired sample t-tests and a last observed carried forward test for any dropouts. The level of significance was set to p less than or equal to 0.5. For the study on the right, the RStudio was used for statistical analysis. They used independent t-tests between treatment groups, so treatment control groups, and then dependent t-tests to analyze change within the group, within the OMT group. And then Mann-Whitley tests for small population, but they didn't have significant results, so the data was excluded. Participant demographics and characteristics. On the study on the left, 26 participants, 6 men, 10 women. Mean age was 41. 1 patient withdrew for underlying unrelated medical condition and 2 dropouts due to scheduling. And they had some other common complaints: low back pain, muscle tension, irritable bowel, and insomnia. The OMT group on the right, there was a control group, N of 10, and treatment group, also N of 10. The control group had 5 men, 5 women, with a mean age of 22. And the African-American 10%, Hispanic 10%, white non-Hispanic 80%. And the treatment group, also an N and 10, 3 men and 7 women with a mean age of 26. African-American 10%, Hispanic 10%, white non-Hispanic 80%. Now, it's important to note that 4 participants dropped out of the treatment group because they missed either OMT and psychiatric appointments. So that leaves just 6 participants in the treatment group. This looks at the comorbidities, and the study on the left, major depression was 90%. That was the most common comorbidity. Panic disorder was next, around 60%, and social anxiety also about 60%. The same in the OMT group on the right. So most participants had a diagnosis of both anxiety and depression. So it was 90% overlap. So they had, again, two subgroups that were overlapping, depression and anxiety. And in each subgroup, one person had only anxiety and one person had only depression. So 4 overlap. 5 participants ended up being, again, that's what I said, in the subgroup. We're just looking at the anxiety subgroup. So for the results, and these are very interesting. For the first study, the mean HAM-A decreased significantly from screening, so visit 1, to completion, which was visit 7. So it went from 26, which a score of 26 is severe anxiety, down to 11, and that's in the range of mild anxiety. 7 patients also achieved remission, so that's HAM-A less than or equal to 7, which is amazing. The intolerance to uncertainty scale scores also decreased, and those were significant, from 80 to 67. And this was a secondary measure, so their focus was on the HAM-A. Now, note that the Beck anxiety inventory scales, they did not differ from screening to final result, 13 to 13. And we'll talk about that in a little bit more in just a moment. And 3 patients dropped out, and the analysis on that found similar results as to the patients that completed the whole study. The OMT group on the right, the control group had no significant change. So they compared the changes from screening to the last week, week 8, and they did it from week to week. And they did not find any change from week 1 to 0, 2 to 0, all the way to week 8 for the control group at all. These were patients being treated with some sort of medication. And the OMT group, they did have significant changes in the GAD-7 scores. So from screening to week 8, these results became significant starting at week 7. And we'll look at that more in just a moment. But note that in comparing the control to the OMT group, that there weren't significant differences in the GAD-7 scores. And so let's take a look at that in more detail, because there's more to it than that. So this is where the synopsis kind of like left it, but there's so much more to talk about here. So these charts are from the original articles of these studies. And here I've just highlighted the ones that are significant. So the study on the left, again, the HAM-A and the intolerance to uncertainty scale had a significant difference. So HAM-A scores went from 26 to 12, 11.9. The intolerance to uncertainty scale went from 80 to 65. And those were significant results. The Beck anxiety inventory remained the same, 12 to 12. Then on the study on the right, they measured changes compared to the initial visit from week to week, because they wanted to see how it unfolded over time. So the changes became significant in the OMT group at weeks 7 and 8. So you can see that here and on the bottom with the p-value. Now, this is looking at that second study, the study on the right. And I just wanted to look at it in more detail. So these are the mean values of the GAD-7 scoring from week to week. And this is the OMT group versus the control group. And it's so interesting to see that trending down from 26 down to 19. And then to note that that's week 7 and 8 were significant. And then the mean from week to week in the control group is just staying the same. Now we look at the changes. So these are still intra-group comparisons. So comparing changes from to the initial visit to whatever week they're on. In the OMT group, this is what we were looking at before, that it was significant change in the GAD-7 score at weeks 7 and 8. In the control group, they didn't have any of Then they compared the mean GAD-7 score from week to week from the OMT group and the control group. And so this is where they are saying that they didn't see any changes. And I'm just wondering if whether either another statistical analysis would have been better. This, to me, I believe, is comparing the mean scores between the groups from week to week. And I would have been interested to see the comparison of the change within each group from start to whatever week they're looking at, and then compare that change to the control group. I don't know if that would have yielded some other information. This is just looking at the what types of the osteopathic assessment and treatment that they saw. They weren't really comparing these, but it's just interesting to note some of the similarities in terms of common structures treated and techniques used. So again, in this study on the left, a black box treatment design was used, meaning the osteopathic practitioner could use whatever they decided was best for this person. And it's a very holistic approach. The study on the right, they had those common OMT findings, and they did have this OMT protocol that was used with every patient, but then they said that the choice of what they used for treatment was at the discretion of talking with the attending physician. They came up what was needed. They also paid more attention to certain areas that came up in the screening, the musculoskeletal screening that the patient reported. So it was a bit more structured versus this black box approach to the left. So there's some questions here. Why did the Beck anxiety score not change significantly? And there are a few things here. The HAM-A, which was their primary tool that they were using, primary measurement, is clinician administered. And so there's that dialogue. You have some sort of rapport, and the clinician could have perhaps gotten more accurate results because there's a bit more back and forth. The uncertainty, intolerance to uncertainty scale, the IUS, is also self-reported, but has a little bit more detail compared to the Beck Anxiety Inventory. So the Beck Anxiety Inventory is known to assess more the fear of discomfort than necessarily actual discomfort, the physical discomfort. And it has, it picks up more on symptoms of panic. Not to say that that couldn't have changed too with OMT treatment, but just to note the differences in the scales that are being used. The HAM-A and IUS might reflect more of the comorbidity of the anxiety and depression, as in this population. The Beck anxiety scale is more for anxiety because Beck has another scale for depression. And, you know, most importantly here, I think, is that the Beck anxiety scores were relatively low at visit 1. So you could have a floor effect. And it's, so the mean, which is of the Beck scores, was 13 at the beginning and then 13 at the end. This is already in the mild anxiety range. Also, the Beck scoring, it's only from 0 to 21, so you don't have as much room to see the detail and the change. But you know, I'm curious to see as to, this would be a different question having to do with the scales, because the HAM-A and uncertain intolerance to uncertainty were measuring something somewhat different than the Beck, because if you didn't see that change, because the inclusion criteria for the HAM-A, they needed to have a HAM-A over 20, which puts them into this moderate to severe anxiety range. And it's curious that the Beck anxiety wasn't picking it up in that range. It still left it in the mild range. So there's differences in those scales being used. Now, this OMT study on the right, well, so why was there significant change within the OMT group, but not compared to the control group? Of course, there's a small sample size. There was a huge drop-off. There's also the effects of COVID-19. So this study was done during the pandemic, and they couldn't continue the study due to the COVID-19 restrictions. And there was this overall heightened anxiety overall. And so that could have been picked up by the study, and then you don't see as much the difference between the groups. But it's still interesting to note that they did have changes, intragroup changes that were significant, and that the control group that was being treated with psychiatric medications didn't see any significant intragroup changes at all. There could have also been some structural differences. The OMT assessment was only done in the OMT group versus the control group because they were using it as a whole, as here's a psychiatric, just the standard of care group, and then we have our standard of care plus OMT group. So they didn't want to interfere with like an assessment, but without treatment. And there was no sham group in this. So how could we possibly improve? Of course, larger studies, but these are really promising small studies. On this first study on the left that we're talking about, we could compare it to a control group. We could have another study like that. We could also control for other therapeutic factors because, again, this was done at a private center for mood and anxiety, and they had other holistic services available, and we didn't know what services these patients were using in addition to OMT. They just didn't have any other manual therapy. This other study on the right, of course, again, larger studies. I would be curious to have a black box study designed to optimize the therapeutic benefit of OMT to not limit it to the protocol, because they were also treating standard of care as a black box. So if we're going to treat standard of care as a black box, then adding OMT, would be interesting to add that as a black box as well, because they didn't monitor what was going on with standard of care. They probably have some data on it, but that data wasn't being reported or looked at in terms of like what medications were they on, what dose were they on, the frequency that they were taking on, and so forth. There's also, it would be interesting to have practitioners with increased experience with treating anxiety with OMT. I know that these were residents. I don't know the background of the practitioner that was in this other study. It was a foreign trained osteopath in the study on the left, but the study on the right, it was psychiatric residents, and so that would be interesting to note. And if you had like practitioners that had been treating more for years and being used that experience with that, implementing strategies for improved retention. This is something they noted in the study, that they could have had a bit more like follow-up in terms of reminders and getting those patients back, and then including other assessment tools. So this first study had the HAM-A, but they also look at 2 secondary tools. And then this one, it put everything on the GAD-7. They looked at the depression, but that was a different scale, not for anxiety. But it would be interesting to have another tool to see, it's like, could we have more significant changes by using a different measuring tool? And then also considering a crossover design. So my summary is that, yes, OMT can be implemented into standard of care to help with the treatment of anxiety. We have lots of anecdotal evidence in many practices, and these are 2 small promising studies that did show some change that was significant. We don't have those studies to compare it to a control group yet, but to keep a growth mindset, because perhaps this is something that we can contribute to in the future. And mainly OMT provides a lot of hope to this population.
All right. Thank you very much for that wonderful presentation. Just a few reminders as we open up the floor to all attendees for questions and discussion on this journal article. First, if you would like to speak during the discussion, please raise your hand, your emoji hand, which is located at the bottom of the screen under the reactions menu. And we ask you to briefly introduce yourself. And please feel free to turn on your camera if you would like. Second, when contributing to the discussion, please try to limit your microphone time to 3 minutes to allow time for everyone who wants to participate in the discussion. I don't have a lot of experience with the timer. I'll try to do the best I can at keeping track of time as people are speaking. But after everyone has had an opportunity to make comments or ask questions, there may be additional time for more questions and comments. And I would be happy to read any questions or comments aloud if you would prefer to type them in the chat. So please feel free to address each other's questions or comments there as well. And before we open the discussion, I would just like to share that this topic of the treatment of anxiety with OMT is something that our DO-Touch.NET pediatric special interest group is currently looking into doing some continued research on. And that's why we really appreciate Dr. Dijamco coming and doing our presentation today on this topic. And so from there, I will open it up to discussion from everybody. Oh, I see a hand up. Yes, Miriam.
I think it was wonderful that you broke the ice on this. It's great. And I'm so glad that more is happening in this area because I personally think it's very useful in pediatrics. And I know, Arlene, I can only imagine, but I know you agree. And most of the people here, that's been their anecdotal experience. So yeah, let's get this documented.
Hollis.
Hi, great presentation, Arlene. I just wanted to share some very preliminary data from my Parkinson's study. Had 90 patients, 30 got OMT, 30 a sham, and 30 standard care. And one of the most significant variables in the ones that got OMT was significantly less anxiety. And they slept better, and they had a better quality of life on all the measures. We didn't use the ones that you talked about, I don't think. It's been years. Anyway, I hope to get this published soon and to add to this body of knowledge, Arlene.
That's great, Hollis. Yeah. I would be interested to see what measures you used and then also more about the sham.
Oh, it was trait state anxiety. Yeah. Oh, and my sham. Oh, Brian can tell you there's no such thing as a sham.
Right.
I put plastic gloves on. I was counting backwards from 7 when I was doing it. I was keeping my knees locked. I was doing Kegels. I was doing everything to not, stop the flow of anything effective. And it was. I actually made a video of it, of the sham and the OMT protocol. So when it's published, you'll see what I did, and so it's
because I looked at some other studies and some they were saying like, oh, but the sham was doing something because they were rotating and doing a lot more movement, and then they got a larger study, and then they're like, no, it's not.
Just in this context, don't say the word MOPSI, and so I try to get a reaction from Brian. It goes way back to then.
Yeah. The one of the second study, the one that was on the right that I was talking about, that was done during the pandemic, they wrote a lot about the value of touch, but I would actually like for the profession to write a lot about not just the value of touch, but what's going on in the osteopathic treatment. Because if we write so much about the touch, I feel like it's not just that, it can water down the significance of the treatment, of the discussion of it.
Yes, Miriam, I see your hand up again.
Yeah, just drilling down into that sham thing. That's just so important. And I've been saying for a long time, we ought to use MD medical students that just say, touch them, spend some time touching them. But there may be a protocol for that. Who knows?
Dr. Degenhardt?
Yeah, so instead of placebo, that might be nocebo instead. which is a model that is worth discussing, but anyway, none that any of us would want to do for sure.
An unethical model.
That's right.
Well, if it doesn't help, then it can't hurt, right?
All I can say, so Arlene, thank you. You went over and beyond what with, looking at the broader scope of articles to present. And I think it really gave us good background of where we stand in regard, we as osteopathic clinicians, in engaging people who are suffering with anxiety. The big question that we need to begin looking at, because over the last year, as Corey had mentioned, we have a working group that Arlene is helping to lead to look at, can DO-Touch.NET continue to expand the evidence in this field? And I hope that this type of review will gain interest along that line. And maybe before the end of this presentation, we can talk about when the next meeting for that group, who are in the process of, designing the study, in case there's anybody who is interested in participating in it.
I think it's an exciting time to be here to help expand on that.
And I would just like to plug, as Dr. Degenhardt was just kind of mentioning, that our next meeting for that pediatric special interest group that's looking into the treatment of anxiety in adolescents is meeting on February 28th at noon U.S. Central Standard Time is when our next meeting is scheduled. And if anybody wants more information on that, please reach out to me at DO-Touch.NET at atsu.edu, and we'd be happy to get you involved with that project if you would be interested. And then I think we have another special interest group that's looking into the treatment of GERD with OMT is our other one that's making a lot of headway. And we do have a comment here in the chat from Angelique. And she says, I often see such a great relaxation reaction post treatment involving cranial. And she always is wondering how long it lasts. Is there any input on that comment? And feel free to speak aloud if you don't want to type back into the chat.
That would be an interesting thing to look at. And I mean, anecdotally, it really depends on the person and if there is ongoing contributing factors versus like past stuff that you're helping them move through. So if it's like due to, say, an accident or birth stuff, then we can like move through that. And it's something I actually tell patients is if I'll know over the next, like after the first visit, I'll know over the next 2 to 3 visits whether there's something ongoing contributing or we're just helping move through past things, anatomical injuries, whatever.
Excellent.
So if there's ongoing stress, ongoing food things to address, then I'm going to feel these restrictions return.
Awesome. Yeah. Makes sense. I love your work.
Oh,
I wish I had that much energy when I was your age.
this was
Got it though.
This was a lot, like combing through. I was like, I haven't read an article with that much detail in a really long time. It's so different when you have to present it versus just like casually reading it.
Absolutely. Absolutely. Great job. Great job.
Thank you.
Yes, Dr. Degenhardt.
So one of the points that Arlene made in the one study design was this black box intervention. And I would like to put that into context regarding a scientific approach to things. Because when we look at the goal of science, it is to be able to learn from our current conditions, people, interventions, what is going to be effective when in the future people with similar conditions present. And when you have a purely black box type of model, it's very difficult. You never can say what was done. So you can't necessarily instruct anybody else to help give them insights as to what to do for a future patient. So it's really really kind of a limited, it is very limited. In fact, in some respect, it's just promoting an art versus a scientific approach from my perspective. But I want to make sure that people understand it does not mean that I'm saying that every person is unique and that there may not be unique factors in the care that is given that's going to help make that work be more effective than a standard type of defined intervention. I think what that challenges us, and it begins with when we're working with our patients and when we're documenting with our patients what we do, is how clear are we in what we have done in order to help instruct us to think about what it was therapeutic in that process. Oftentimes we will use, well, we did cranial work. Well, does that tell anybody of us that if I did cranial work, what I did and what you should be considering when caring for a particular patient like this? So this is something that DO-Touch.NET has worked on quite a bit, is how do we develop our observational skills? And these are our observations more than just our visual skills. How do we define them so that we can actually compare across a population to see what are the factors that are consistently showing association with improved conditions to help hone in aspects of things that might be therapeutic in that process. So I think that's a really important aspect of, as we design this next study in this field, that we really need to figure out ways that we can advance that aspect of the data that hasn't been collected in the past.
I'm wondering, looking at the study that did have a protocol, because if it were more detailed, like what they were looking at it, when they had the protocol, they didn't say that they were using every single technique in the protocol, but they at least assessed all these areas and decided within these techniques if they should be used. But I almost would like more detail to the protocol, because to give actually more variety in the treatment, because there were certain areas that I see in patients that with this protocol, they wouldn't have been addressed. And that's difficult.
And to me, that's why we have to be more specific on what we observe in the patient. How does that drive what intervention we do, and that we clearly define the intervention that we perform.
Arlene, could you expand on what your observations were from?
On the protocol?
Yeah, because I kind of see the black box as being, it gives maximum freedom, but then as Brian's saying,
right.
It seems like it brings maximum insecurity scale. And then
that worked because they had one practitioner, and so it was sort of like standardized like that. So one person treated everybody. And but again, it's like, they listed what she did afterwards that was in the report. It wasn't, they didn't put any analysis on it. They just said common structures treated, OMT techniques used. So in that way, like, that's interesting information to pass on and could be taught. But I guess in terms of the art of, like, how did she arrive at that, that could be flushed out more as well. And then for the other group that had a protocol, they basically listed the techniques that they used, and it said soft tissue, fascial, so myofascial release, direct and indirect treatment, BLT, rib raising, counter strain, muscle energy, osteopathic cranial manipulation, and they put suboccipital release, venous sinus drainage. So I don't know if that means they addressed other cranial areas, or they left it at just those two things. I don't know if they, I'm thinking they said it was a protocol, so this was at least looked at with every patient, but I don't know if that means, did they do other things in addition, or was it limited to just this? And you know, it would be interesting to see like what was actually used from patient to patient. I know it's sometimes hard to record everything, but there should be a way to be able to pass on the information so that it's useful for other people, for other osteopaths, and because that's the point, is to be able to pass it on.
Well, unfortunately, our live discussion time is up for this week. So don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel. So if you have any further comments or questions, we can continue any discussion on that channel within the comments section. Watch your email for announcement whenever this recording is available. Thank you again, Dr. Dijamco, for this wonderful presentation. Announcements, I do want to just let you all know, and there will be a formal announcement coming out in the newsletter next month, but at the beginning of March, Jane Johnson, our associate director, is retiring from DO-Touch.NET, and so she will be leaving us. So if you want to reach out to her, feel free to reach out to the DO-Touch.NET email, and we would be happy to forward on any messages to her. Other than that, our next Let's Talk About OMM Research episode will be in April. More information on this webinar is to come, so keep an eye out for that email, and we will be happy to see you all then. And other than that, have a great day, everybody.
Thank you, everyone.